FP, that is on this cesarean side, then that means there is a way of managing the patient right from the antenatal period that matters the most thing. And so in that case, so if I got the answer of what and how, now if I ask you straight away that being a company, if we are so keen to shift that number a bit towards the induction side, then what is that as a company we can do on a larger scale in the gynae clinic? Be it say just a patient education, probably that is something which is now happening all across through the social media, and that is not something which probably is taken in a positive sense every time. So what is it that directly appeals the patient that can be done by a company, by any mode that you suggest that can be more effective? And so your job being a obstetrician becomes a bit easier to take those patients for the induction, be it through improving the health, overall health of the patient throughout the pregnancy, not only by giving medication, but by proposing some kind of exercise, as you said, that exercise and a physiotherapy and all, or what else that can be done?
And most important thing is one can use these things only when you have got a good team. A team is very important. You really need good midwives and good supporting staff, because a single man army, it is very difficult, because you can't, means you need staff in the night. Even if anything happens in the midnight, there should be staff to attend this patient. One of the reasons in India for increasing rate of cesarean section, especially in the private sector, is deficiency of well-trained paramedical staff. And that is the biggest problem. Because if you have that, then the chances of your successful induction are very high, and unnecessary cesareans will not happen.
Okay.
So we really need to train our paramedical staff how to monitor these patients, and how to reassure the patients and all that. So I think at the same time, training of paramedical staff is very, very important.
So you feel that that can also be taken up as a task from either an NGO or a pharmaceutical company, along
Yes.
with some kind. Yeah. Okay.
Yeah. You can
Okay.
take some, I mean to say, paramedic midwives, CTG training, how to do CTG, what are the early signs and all that, how to identify, when to inform the doctor. So I think
Okay.
then they will take interest once they know what's
So
going on.
quick learning modules of on a
Yeah.
small task can help them to, okay.
Yeah. Because you must be
Okay.
having that social responsibility, no? So in that you can, your CSR activity, you can train the paramedical staff.
Okay. Sadhna ma'am, Ashwin sir, your comments on this, sir. Sir, you are on mute. Ashwin sir, you are on mute.
Hello, good evening.
Good evening, sir.
Hello. Good evening, Parag. Good evening, Asha ji. Hello.
Good evening. Good evening.
So I think you want that how corona remedies can contribute. So this is thing that like the whole world and especially in India, na, we are focusing on reducing cesarean section rate and the increasing vaginal delivery rate. So the Survidel can really come in a very, very big way, because now we have a lot of data and experience. And to me, that you focus on the public health institution doctors, because in public health now, the especially the vaginal deliveries are like coming in big number in public health facilities because of all government facilities, free medicine, and a good infrastructure for labor room. So focusing your programs, and we can be a lead like any way in the programs, and for conducting and something, but the going to residents, going to the district hospital. Now we have every district medical college as well. So focusing on that will really give them the push, because they have residents also, so they can monitor the fetus and everything, and they can take like the especially the low risk patients are coming to them. And here is the thing that how this can change. So this can be a real game changer. But do me what my extensive travel across India, that the for vaginal delivery low risk, the private healthcare facilities is now not in that choice for the majority of population. So, and coming to the cost and everything and how you can make available, that is something Corona have to look, that it can be like a prostaglandin or the cytolog, you can make it available at reasonable cost. So these are few things which come to our mind, because as a very senior or something, the people are coming for high tech and very high risk pregnancy to the private sector. So these are few things which I wish to see. And I've joined a little late, 5 or 6 minutes, so maybe I have missed something in
This
that.
was just the beginning, ma'am. So we are into the initial part only. So it's fine.
Society CME, where we really invite the medical college
We are
people,
coming, yeah.
the main and the periphery medical college, and they can share experience. And you can give, like when Survey Prime Weekend, I was the first one who I got the samples and then I used, and I became very confident about the Survey Prime gel. So this is something that you should start somewhere. And all good thing, because the thing come and they are not doing in the cold chain, like they are not putting into the appropriate temperature, what we had in our meeting. So that is the thing, that here is another. If they don't use rightly, then they will not have that good experience. And we
Okay.
can get the international data, because abroad it is being used like anything as a labor induction.
So, as per your opinion, ma'am, the follow-up CME should be at public health institute or might be the government sector hospital where residents are practicing over there.
Can involve the Foxy societies, and we then the society organizer should actually say, and you can go directly also. So we are there to help you out, but you can go directly either through society, or you can go straight away to medical college district hospital, where a lot of like a huge number of vaginal deliveries are happening nowadays.
Fair enough. Yeah.
Ashwin sir, you started something.
I would say that concentrate on B-tier cities. As Sir said, you need to look for an obstetrician who's patient enough to deliver women vaginally. Cities like, I'm come from a small city of Kalyan. I have 4,000 deliveries annually. So you have to select an obstetrician who's, doing that much amount of work. As Madam said, dentist officers and medical college. Once you concentrate on these people and you train them, these are the kind of people who will come out and do vaginal days after they've passed out from their MBBS or after they've passed from their MD or MS. So you need to first look for a doctor who's patient enough. A doctor has good obstetric practice. Going to an IVF consultant and saying that अभी आप ये सर्विडिल यूज करो, वो कभी यूज ही नहीं करेगा. तो आप
बस सही है।
ढूंढने हैं जो आपकी सर्विडिल को आगे यूज करे और उसको कोई मतलब है सर, वरना it
Point
just
taken.
doesn't. You need to look for obstetrician who's really. You may have 5 in a city, but you need to look for those 5 who will really use your product.
Okay. Fair.
Fair enough.
You are mute, Dimple.
So, Dimple, we can move ahead now.
Still you are mute.
Okay. Yeah. So is my screen visible?
Yeah.
Yeah.
Yeah, okay. So thank you so much. So the next topic will be defining the right patient profile for induction of labor. So if we look into India's maternity stat, this is some stats and numbers that I have came up with all the data that are available with us. So according to UNICEF in 2024, 2.5 crore total birth is happening in India per year, right? So out of which the normal delivery is 78.5%, which is 1.96 crores per year. Okay, so according to WHO, 25% of vaginal deliveries requiring induction of labor. So which gives us 50 lakh women per year is requiring induction of labor, right? So which is 20% of total birth. So out of total birth, 20% of deliveries are requiring induction of labor. So this is all the numbers that I have gotten through data like available. In government setup, it is 54.5% of the birth happening, 28% is happening in private hospitals, and 17.5% of the deliveries are unattended or it is happening at home. Okay, so this is something we will be discussing further, but at the same time, this is the FOXY recommendation for induction of labor. So these all are the indications, or we can say complication when happens, how IOL should be done in such kind of a condition. You can see the weeks and all. So what we wanted to know, do you all agree that this 20% what we have came up with the data available, is it the number that you are also feeling that 20% out of 100 patient, 20% are requiring IOL, or it is different? It is higher or it is lesser? What is the actual clinical scenario for the same in IOL market?
It could be higher depending on the kind of patient profile you have. Now, in city like Pune, we have almost 30 or to 35% of our women who have gestational diabetes mellitus. So all these women would require induction of labor sometime or the other, right?
Okay.
So similarly, women who have hypertension, because that is also one of the big challenges, and Sadhna will definitely agree on this. That, these are the women who do require. So 20% is probably little underestimated.
Okay.
It could be higher, but then, having said that, in medical colleges, what I remember of the medical college practices, and I'm attached to a medical college where we are not somehow inducing as many patients. Many a times they go in labor. Palani has also joined, so Palani will be able to tell us what is the current scene
Hi, Parag.
in
Yeah,
a
thank you for
medical
having
college.
me here.
Palani.
Hi, Asha. Yeah,
Hi,
I
hi.
agree with Dr. Parag that many a times in the medical college, the incidence of induction is definitely 25-30%, something more than 20%, for the very simple reason, like Parag said, it may not be hypertension, it may not be diabetes or any other medical disorder, which will be absolutely indicated induction if we will put it within codes. But for example, when we say a 39 for weeker who does not go into labor by herself till 39 weeks and has no other comorbids, we would think in terms of inducing labor for that so that she delivers before 40 weeks. So what do you want to call that as elective induction? Then this elective induction numbers will be very high. Leave alone your growth restrictions you're inducing or you're doing a section, your hypertension you're inducing. That is a different story. Apart from that, no risk factors, low risk primary gravida, we will think in terms of inducing at 39 weeks plus. Okay, so that we will not cross the magic figure of 40. And so we would do, and now having evidence, the ARRIVE trial coming into picture, in a medical college, I will start thinking in terms of inducing her at 39 plus 2, 3, whatever, so that I'll go on the ripening very slowly and then maybe inducing, and so that they deliver by 39 plus 6 or 40. So the induction rates are quite high in our institute, and we almost get 90 to 95% normal delivery with the induction group. That's what I'm trying to say.
Okay.
90% is really a good figure.
No, 90% of the induced labor, that's what I'm trying to say. I'm not telling our delivery rates are 90%. No. Medical college, our section rates are 35, 40%. So 60% vaginal delivery. What I'm trying to say is, of the inductions which we are doing, our deliveries are vaginal deliveries or AVDs, assisted vaginal deliveries are 90%. 10% will go into fetal distress, whatever, and do section.
That's great.
Okay. So I think whatever the number we are going ahead with is more or less in sync with. Suppose if I'm thinking for targeting at least this 20%, which somewhere will probably, that's not the wrong number that we are taking up with, isn't it?
This actually, I agree with Parag and Dr. Palani that induction of labor is actually much high in most of the institution, and patient also it is not considered like it is for convenience of doctor or patient, but that also important because patient are coming and now their husband has got that much of leave and we have to arrange. So this is something the real life scenario that patient also demand induction of labor and they are okay that yes, if needed cesarean section can be done. A few things which you should actually focus on this. That misoprostol in full-term pregnancy is something still considered a risk, and especially when we don't have that tablet which has to be broken and the 25 microgram, 50 microgram, 100 microgram, and things are not that clear. And on the real life interviews that we do get hyperstimulation with misoprostol, because especially I think that the scoring and how you break that tablet is very, very important, and the meconium aspiration. So the dinoproston pessary that has got a we do get a little bit, we have to the fetal monitoring good, but that is the something very, very important that cervidil pessary can be taken out if there is a fetal distress or something hyperstimulation, so that really which is not with the misoprostol as well as with the Cerviprime gel. So this is something very, very important, and to me what I have gone through the paper that it has got a better profile, safety profile for the fetus as well as the mother, because cytolog has got all the issues: breaking tablet, hyperstimulation, meconium aspiration, fever, which is sometimes scary, especially we are doing with the prom. So there is the something that you must focus, and you must like because this is something very good in my personal experience, like few relatives at abroad, GDM and high BMI, and they got the cervidil and they had a very good outcome. So it is something personal, something from research. So that how it has got the above cutting edge over misoprostol as well as the Cerviprime gel, because you can remove it anytime, you can take it out anytime, and that is something, there is no confusion in the dose. It is only once application. Dr. Kakkar, I think what I remember that he uses sometimes twice, but it is usually once. So there is no confusion in mind of doctor and resident that how it is to be used. So these are few positive points that we have to be very emphatic that how this is friendly for the doctor, friendly for the patient, and has a very good efficacy, and it has got the better safety than what in agents we have got with this. Oxytocin infusion is very, very good physiological. The beauty of oxytocin is, again, you can take it, you can stop the drug, but that need IV thing, patient has to be lie down, she cannot ambulate. So this is something I think where you should plan your educational material like that.
Okay.
Definitely, we can do that.
So dinoprostol core over misoprostol in terms of like various side effects such as meconium aspiration, even like stimulation, which probably would be there and you cannot retrieve it back. While this is like on and off switch. Once you like cut short the supply, obviously you can retrieve the side effects.
True.
Fair enough, ma'am.
And at the same time, oxytocin is just giving the contraction, but when we talk about dinoproston, it will be giving cervical ripening followed by contraction. So
So
definitely,
Dimple, we have to remember that oxytocin was used for induction of labor only before the prostaglandins came in. So in the 80s and 90s, early 90s, we did use it. But once the dinoproston gel that was introduced somewhere around 94, 95, most of
yes.
us have switched to dinoproston for ripening, and then oxytocin is used only for augmentation of labor.
True,
Right.
true.
Even if you refer to the Foxy ICOG guidelines, which were released in 2018, we are
18.
talking mainly about prostaglandins only. Misoprostol, personally, I have never used it. Somehow, I was not very comfortable with the hyperstimulation, the meconium aspiration, and even some losses that we had. So I always used dinoproston gel. So currently, what we are doing, coming to the third point, that is patient profile. When the induction is a must and Bishop score is very poor, I would prefer Cervidil. If the Bishop score is little better, then even prostaglandin gel is okay. But I have always used Cervidil only when the bishops was really very poor, and it has worked well in all these
So
cases.
what would be the range, sir, where you prefer a Cervidil
So
most
zero to
predominant?
maybe 0 to 6. Not,
Okay, 0 to 6. Okay. And which are the patients category where you go for a gel?
Then see if the cervix is partially dilated, maybe say 2 centimeters, 2.5 centimeters, maybe
Okay.
effacement is little better, cervical position is anterior, and then if there is need of induction, then maybe dinoproston gel would be simpler
Okay.
because
Okay.
if
My
the bishop
my
score is
only
very poor. Yes, Asha.
My only criteria is if patient can afford, I would definitely go for pessary, and if she cannot afford, then I would go for gel. I've been using gel since I would say 1980, 87, 89, because I've been trained in England.
Yeah.
So since then, so I've never ever used oxytocin for induction of labor. So I'm used to that, and since I started using the pessary, I hardly ever use the gel, and if at all I use it very compromised patients. Otherwise, I'm very comfortable because I have lots of high risk patients. All these IVF patients, I see to it that they deliver vaginally. I'm not a person for cesarean for all my IVF patients. So I'm very happy inserting the Serviprim or other product, and the results are excellent, and the safety margin is very good. And if there is like some if patient is having lots of pains, then we have got epidural services. So with that, the things settle down. Or even if patient has really got tetanic pains and you take it out, and still the physiological contractions will continue, the effect will be there, and patient will deliver vaginally. So my criteria is only financial. If you can afford, go for this.
But ma'am,
In
in case
private
of
sector,
gel,
Asha, that's not really a big deal.
Yeah,
Um,
so that's the only criteria. Otherwise,
yeah.
I'm always using uh, this pessary only.
so ma'am, in case of gel, there are multiple gel that you need to insert. Like one after inserting one gel,
Yes,
you are not
yes.
getting. So anyway, it is getting expensive in few of the patients also over there
No,
also.
no, no. At the
Okay.
most, you need 2 or 3
So,
inserts. So that's not
so 2 or 3
expensive.
gel will suffice the purpose for any of the patients.
Yeah,
Yeah.
yeah.
Okay. Okay. Fair enough. Yeah.
So another thing that we wanted to like see is this is what the recommendation says for IOL, right? So in all these indication that Foxy has recommended, can we use Cervidil, dinoproston vaginal pessary for the same recommended time? Or do we have any certain different opinion for
No, no,
Cervidil?
no, no, no. See, when we prepared these recommendations,
Hmm.
that was for induction of labor. So it's not
Yes.
uh, only
Product
for
specific.
gel
Hmm.
or yeah, it is not.
Hmm.
Both can be used. I mean, you can use
Yeah.
the pessary,
And
you can
for
use the
preterm
gel.
rupture of membranes, you are not going to use
No,
pessary
we
or
will
the
use
gel.
it. Asha, there was a time when
Hmm.
PROM was a contraindication or for use of pastry, but not anymore. We use it.
So
So
now
Okay.
there
at
is a
rupture
no
of membrane, we used to
contraindication.
remove it earlier, but
Yeah,
now
this is
not now,
not
not now.
contraindicated. It is like benefit outweigh the risk, then obviously clinician choice. Like you can use in PROM also. Now there is no contraindication. Earlier there was a contraindication.
Okay, that's a new thing because I don't use it for PRON.
Use it and see because
Okay,
if the cervix is really bad, it'll work wonders.
right.
So
So
everybody is aligning with the Foxy recommendation of using
hmm.
like induction of labor for this all sort of disease as per the timeline, right?
Yes.
Yes, yes.
Yeah.
I, some of us were part of this guideline committee.
Guideline.
Yeah, sir. Yeah, obviously that
So
is.
because when we did release this, I was the secretary of ICOG and Dr. Asha and Dr. Sadhna were on the governing council. So all of us
Okay.
were indirectly involved in it.
Yeah, yeah. Okay,
Okay.
so let's move on to next topic, right, sir?
Yeah, we can move on.
Yeah. Yeah. So now we'd like to know the Cervidil's role and positioning in IOL. So this is just to give a brief. It is more than a pacemaker. It is a smart induction tool which we all know all the functionality. It is 24-hour release, which mimics our natural physiology, immediate removability, simple application technique, ambulation can be permitted after 30 minutes. It is single dose administration, and it gives dual function, ripening and contraction as well. Okay, so I have shared one checklist with you all through WhatsApp. So that was the checklist that was prepared earlier with the help of you all only. So we just wanted to know, is the checklist enough to have any new user or any early career gynecs to have a very successful first experience? Or do we need any other tools to help any new users or early career gynecs? So I would, so this was the checklist that I have shared you. So, and at the same time, I also want, is there any need to like short down this checklist, or is there any need to add on something into this checklist?
To be practical, it must be not more than 4 or 5 points, because too long we think that everybody is happy that we have like a crumpled into Almira, but actually it should be that it is always in our mind. These are the things which is not only the tick, it must be in our mind. So I'm not like a very 20 point, 30 points. Actually, it is only for our happiness, and actually usually it is not. So it should be very, very simple. 4 or 5 things. I think what you have said in the previous cesarean section, what you consider, I want to know that it is a contraindication, cervical pessary. Just I want to know what you have said, that previous section or previous uterine surgeries. This is something very important. And of course, priming, the Bishop score is less, and she thought. So to me, a very long, very like a long list. It actually serves.
Definitely. So, ma'am, if we have to consider 4 points or 5 points, so which 5 points should we consider? First, as you have mentioned,
I
we
think the
need
parity, that is very, very
parity
important,
matters.
because high parity, we are really concerning about anything which can cause pain. Age, I don't think. BMI, I don't think. Asha, let's see what Parag says. Bishop score, yes, more like remote from the term, as well as the low Bishop score. That is the indication. That is something, the indication for cervidil. And post date, nahi. So this is the indication for induction of labor. Diabetes, I don't think. Medical disorder, we cannot say, because that is the indication for the fetal weight, of course, not macrosomia. And one thing important, any fetal growth retardation, which is oligo with a compromised Doppler, that is something about any method of induction. This is something which we will like to have a caution point, red flag sign of individualized decision by clinician, you can say. Freezer before, yes. That is
Yeah, that is
something
important. That is important.
वो उसको पॉकेट में एप्रन की पॉकेट में लेके घूम रहे हैं सर्विडिल, और उसको डाल दिया, दैट इज नॉट गोइंग टू बी इफेक्टिव. सो इट इज समथिंग वेरी, वेरी इंपॉर्टेंट. But I think it is not in checklist. It should be included in your something SOP or something SOP. Like no guidelines for its use. Yeah. Time taken, yes. नहीं, ये तो checklist में नहीं. I think these are the thing which we have to monitor.
To keep in the mind.
No, that is not checklist. Checklist now, you want to check this patient is okay with a cervidil use. And the second thing is that what you have to look into, and the induction and anything is specific with cervidil. So that should be, I think, in 2 parts, 5.
Okay, yeah. So we'll make 2 parts of it, out of which one has to be very crisper thing, and one has to be SOP, what you have to do next, and what you think has to be kept in mind while using cervidil.
So my question, Sadhana and Asha, you can also respond. They mentioned before inserting cervidil vaginal insert, 20 ml 0.9 saline wash is used or not. I have never used it.
No, never.
I have never used it.
Never.
And that is not what is recommended also.
Actually, there are few papers which says that it actually increases its efficacy markedly. So this is
Oh, is it?
something which is not, it makes a little bit cumbersome also, but that was the study was.
Yeah, few of the evidence article that is like supporting this 0.9 ml NaCl saline wash, which is like increasing efficacy a bit, not to the gross extent, but yeah,
But then
bit
that is
increase
messy.
in the
That is
efficacy because
messy.
of the aseptic environment which is being maintained in the vaginal flora.
May I respond? So when you use 0.9% saline and things, you're washing out the natural lactobacilli, etc., and then if some infection comes in, your cervidil will be responsible for that. So I don't think with weak evidence of having 0.9% saline wash, we should not put it as a checklist. Just take it off.
Okay,
Okay, sure.
fair
sir.
enough, fair enough.
Done.
Yeah.
So by this discussion, like I would like just to know, if not saline wash, so we are giving no wash, or any another wash we
No
are
wash,
giving?
no wash.
No wash.
No wash.
We don't
Okay.
wash it.
Okay.
We just
Okay.
use some lubricant when we are doing a vaginal examination, and that's it.
Okay.
Fair enough.
Yes, sir.
So, in the interest of time, what I would suggest over here,
Hmm.
we'll share this checklist with each one of you, and in the
We'll
based of like your
Hmm.
understanding, we'll refine this list again.
Nimesh,
We can
can
make
I add
one
on that?
SOP and one.
Yeah.
Can I add
Yeah.
on that? So with
Yeah,
the
yeah, please.
checklist is very huge, as what Dr. Sadhana there was telling, and I think we should have the parity and the Bishop score, and then put one column saying any contraindication, any other remarks. That's all. So in the remarks, somebody can say macrosomia, somebody can say IUGR, etc. So you have only 4 points in it: the parity, and then the Bishop score,
Yeah.
and then you can say any remarks, any other contraindication. So then when we say any other contraindication, in that it will come whatever you want, you can fill it up. So these 4 or 5 points can be the checklist. The checklist is very huge, and we will definitely not be able to go through the checklist and fill so much before we, put the process of insertion of the cervidil is very easy, but the process of filling the form is very difficult.
Okay, sir. So this is a practical aspect.
So what I understood is that we can have
Yeah.
a small to-do list and small what to watch list. That's it.
One more
Yeah.
thing.
So Dimple,
I think
change what?
somewhere I saw that concomitant use of other agents. So
Yes.
what is your view on that?
No, that will come later on, no, Asha. See, we
But
put
here
a cervidil.
in this checklist, I think they have written somewhere.
Yeah,
it's
that's what
not
I'm telling.
needed
That need
there.
not come there. That is not needed. See, whether you use oxytocin, today you induce with cervidil, tomorrow you use oxytocin or artificial rupture of membranes or whatever, or augmentation, that comes on a separate issue. That is not for induction checklist.
So not in this, it should not be there.
We can
Should not
omit
be
that
here.
part also. Yeah.
So
And
we can make
honestly, if we are starting oxytocin, the cervidil has to be out.
Has to be
So
out.
you cannot
Only
have
one
cervidil
agent
in
at a
place
time.
and add oxytocin. No.
Yeah.
Yeah,
Then you
that's
are,
what the recommendation
sort of.
is. 30-minute gap should be there. Once you
Yes.
Yeah.
Yes.
Absolutely.
oxytocin, 30-minute gap should be there.
I think
So
that has
Dimple,
to
as
be
Dr.
emphasized.
Palani said, just have a checklist of 4 points, what Dr. Palani has said. That's it. And share it so that everybody will comment on it.
Comment on it. Correct. I'll do that. And sir, is there any practical challenges with cervidil that you have experienced through all, like how this long you all must have been using? So were there any challenges?
Cold chain. Cold chain is the biggest challenge, because if it is not kept properly, then you will not get. My initial cases, I think for 10 cases, I didn't get any effect. And then I was very, very angry, because we don't know what happens. The person to me is giving, but how the cold chain was maintained is very, very important. So I think we have to emphasize on the cold chain.
Okay.
So ma'am, in hospital setup, how one can maintain the cold chain very fluid, like flawlessly, like as you have said, in 10 cases you didn't get proper results, but later on you get. So what did you do to get this like cold chain maintained at the hospital setup?
I asked everyone to be very cautious, not to take any pastry which is not cold and all that. So unless you are really strict, everyone has to be very much sensitized that it is not. What will happen is midwife will take out for one person and then again keep it. So that practice should not be there.
So, जैसे the gonadotropins and the vaccines we are particular na, so if you can like try that the two thing actually you can do, that will be the added on benefit, that you supply direct from your anything,
Storage.
the place of production,
Depot.
like sometimes gonadotropin and vaccine we demand it, and you can also give the subsidized rate to those doctors who are doing this. So you can have the double benefit,
Okay.
and
There should
yeah.
be some
people are assured. So
indicator.
it is like the other drug where strict cold chains.
And some indicator should be there. If it has at all been taken out from the cold chain, that indicator has to be there.
Got it.
Okay. Got
Got
it.
it. Got
Okay.
it. So like
Okay.
it used to be on some vaccine vials and all that they are having that
Yeah.
cold chain breaking color change and all.
Yeah.
No sensitive
Mhm.
indicator.
And
Okay.
sensitization of pharmacy also, your wholesale market seller and the retail. That
Mm-hmm.
sensitization is also from your end, that should be. Because I was the part of that path oxytocin project, and this was really eye-opener that 90% of oxytocin was ineffective because everybody was putting the oxytocin on the shelf. So this is something that we worked a lot, and now we see everybody, gynecists are aware, and the pharmacy people are aware, I think 30-40%, but you have to sensitize your wholesale and the retail person also. It is not only from us and you and me, but in between also.
In between. Yeah.
So we are designing on that line also to like upgrade the retailer as well as stockist. We are putting our efforts on that line also
Yeah.
to
So
address
we
this
need.
cold chain
Hmm.
issue.
We do have marketing colleagues right now. A couple of marketing colleagues and seniors they have joined the meeting just because to know those kind of practical aspects also. And I think, and we also will convey, but for sure they are also taking
Hmm.
a note of it.
Yes. Yeah.
So for
Definitely.
sure we'll be taking it to the next level.
Yeah, this
Yeah.
point is very well taken in our all the business meetings, cycle meetings. The team is explaining the importance of the cold chain and we are also taking the help of logistics. So, we have the absolutely deep freeze transportation from Ahmedabad warehouse to CNF. CNF also we have the temperature log, so everyday transfer temperature is being recorded and. That further is being dispatched to the stockist. We also have the temperature maintenance for that, and from stockist to the end user, that is the nursing home, we have advised them, this need to be given point to point. So many a times happen that stockists go to the, two places, three places together, and there are chances of the disruption of the cold chain. So we take care of that, and point is well taken. We will further sensitize our team and our sales team as well as supply chain team to ensure the cold chain should be in a right way.
So it has to be
Yes.
treated like vaccine, basically.
True.
True, true.
Very true. Mhm. So yeah. So one more question, that other than checklist, do you all feel there should have to be any other tool that will help us help the users other than a checklist?
Video
The
of
way it is
insertion.
inserted, the way which is
Video.
inserted, I think
Okay.
the longitudinal axis should be perpendicular to the vagina so that
Hmm.
the action is better. So that needs to be told to the user.
User.
So,
Video.
Especially
Abhi the
the
new
first time
generation
users.
is hooked to video. You play
yeah.
video, give them WhatsApp video. Video is
Yeah.
very, and
So
that
we
is all
already have.
captures.
Yeah.
So
Yeah.
we have compiled one of the video we have already shared with few of you
Yeah,
already.
yeah, yeah.
But
So that
we'll
that
take it
that
and we'll
video
use
would
it as
suffice
an
for us.
effective tool now.
That will suffice. But my question is, when you're giving it, promoting it to a new user, I think it's
Mhm.
important you tell that it is placed horizontally
Yeah.
in the vagina.
Yeah.
Got it. Got it. Got
Okay.
it. Got it.
Okay.
Done.
Fair
Okay.
enough.
So moving back next to sharing feedbacks and addressing the barriers. So mostly we have covered this part. You all have shared your experience. So we all have got an ample amount of experience with dinoprostone phase 3 usage, and there are big number of gynecologists who are not even aware how it is being used and what is this. So you all have suggested us some tools that we can definitely we, and we will also need that we you spread the science that you are like what you have been experiencing. And for the same, we will be conducting CMEs also. We'll be talking further also about that. In CMEs, you will be sharing your experience, how have you used, so that the new users will get that confidence with all the experienced gynecologists. So barriers we have mostly talked about. Cold chain, how we can manage that. Cost, so for the cost purpose, I would like to ask everyone that how do you counsel your patient addressing the cost? The cost is what, so how do you counsel your patient regarding cost of the product while using Cervidil for induction of labor?
So in our practice, we tell them that this is one product which has given better results as far as vaginal birth is concerned, but it is expensive. We tell them that there would be an addition of around $3,000 to their final bill. So I'm totally into private setup, so we tell this directly. And then as compared to the other option, the gel, what we have seen in our practice also is that the results of uh, induction and a possible vaginal birth are a little better. This is this is how we counsel.
Correct.
I would like to add something.
Yes.
I tell my patients that it lasts long actually, in comparison to the other one, so that we can wait for 20 to 24 hours. So with this, they get counseled easily.
Okay,
This
okay.
is a one-time dosing thing.
Yeah.
Yeah, and then we have to prepare them mentally also that it's going to be a long waiting period, and they have to be patient.
Patient.
As we as obstetricians are patient.
Yeah, both has to
True,
be
true.
patient.
So I just remembered just before 5-10 minutes, Asha ma'am just told about the earlier time when she used to prescribe 5,000 rupee product, and at that time the cost 5,000 rupee was genuinely a very huge cost, isn't it, ma'am? So now if I need to just rephrase the same question, that compared to that, is this 3,000 rupee, 5,000 and 3,500 rupee cost still the higher cost to the patient?
Yeah, it has come
Would it
down.
be a problem statement to address aggressively?
Actually, anything which is good, मुझे नहीं लगता कि बहुत ज्यादा लाइक प्राइवेट सेटअप में ये बहुत बड़ा इशू है. Anything we say for any vaccine which has come, that it is something like people are today very accepting, very, very highly, any new thing, any better thing. This is a competitive world. So we are having the good thing and the bad thing, everything about it. So अगर हमें समझाना ही है, then we can say if we give anything that is the repeated insertion, then in Cervigel, what is the, it is a per speculum examination, patient has to be in the labor table. So no interference, many patients don't like it at all, and that's why the misoprostol actually creamed it. And the residents, जहाँ पे बहुत huge number में deliveries होती है government health setup में, so this thing, the Cervi-Prime, we put it so like a time, they have so many things to do, so that time is less. So the practical utility is too high, and 2,000 for government setup, that you have to say that how you come into that. It is also one of the essential drug in the labor if the government want to reduce cesarean section. But in private setup, I don't think that it is much, because whatever we do, misoprostol is only the thing which is very cheap. But Parag also shared it that we have a undercurrent. हम लोग सामने नहीं बोलते, but what we have the real time experience that people are really scared of it, and high dose, how frequent dose, side effect, and all the fetal issues. And now the people don't accept at all any fetal complication. This is something a very crucial part of time of obstetric practice. So this is something. So in government, you have to sort out the ways. And you have to focus that if any drug which can efficiently reduce cesarean section rate, that should be the part of any like a services. And in private setup, I don't think that people usually mind it. And not much calculation. If you say this is something very good, best till now it is one of the best things, they are very happy about it.
About it.
It
Oh,
is
and they have to deliver once or twice only. They have already Googled everything and they want the best experience. So I don't think it's usually a big problem there. And most important is to let them know that 24 hours don't expect labor. It is just for preparing the neck of the womb. So if they are well prepared, and I ask them to watch, play games with the husband, do exercise, enjoy your own husband-wife time together 24 hours, and then so that way they usually accept it, and there is no problem, and cost should not be a major thing most of the time.
Yes.
So
So,
if counseling
yeah,
is properly done, then cost is never a issue.
issue.
Okay. Yeah. Fair enough.
Yeah. So long waiting time. We have so all the issues can be addressed by proper counseling and patient awareness.
everything good needs waiting.
Exactly. So labor is the process of waiting, right?
फास्ट फूड देख रहे हैं ना, फास्ट फूड क्या कयामत ला रहा है ना इंडिया की हेल्थ में. नो.
Yes.
Yeah.
So
All
like
board games should be provided, playing cards should be provided so that the patient passes her time those 24 hours.
Yeah, this is a good idea, huh, ma'am?
good
From
idea,
marketing point of
actually.
view. Yeah.
Actually.
Okay.
So next, talking about the real world evidences. So as Parag sir said already, we have very limited Indian data. So recent data is needed to be generated. So we also wanted to work in that line. Also, we want to. So there are multiple international data already published, but Indian data there are none. However, we are using like. Kakkar sir has used in more than 2000 patients, around 2000 to 2500 patients. So what we can do collectively, we can collect all the data that you all have done retrospectively, and then we can go for the largest RWE study for cervidil or dinoprostone vaginal.
So it is either way, either we means
Yeah,
or both the
exactly.
ways that we can collect the already used data and then make a collective retrospective publication for the same.
Correct.
At the same time, we can also go for the prospective user experience data collection from the users already in this group, as well as who are now getting more and more convinced to it, so that the conviction level would go to a different stage.
Next level.
आप
Yeah.
सैंपल दीजिए HODs और टीचर्स को. हम लोग लाइक 1981 जब दुनिया में बहुत कम प्रोस्टाग्लैंडिन था, देन इन आगरा मेडिकल कॉलेज वी हैव 4 theses running on the prostaglandin for the induction of labor, the termination of pregnancy, IUFD. So give your samples to teaching people and they will are very
So
happy
student
to
thesis
have
kind
the
of thing.
update thing. Yes, for the thesis, and that will be very, very robust because they have all the time. They have to present thesis in their examination. So yes, you go for private sector, but like we all are there. If you present any like something protocol and research, we will say.
Yeah.
But that is the thing that because we remember in 1981 in Agra, we have the radioimmunoassay. That was the first thing in the like in India. And then we have the prostaglandin, and we were so confident when it came. We were so confident that it really works remarkably. So that gives you real confidence, and they have already system in place for thesis because
Okay.
they have teachers and professors. So you have to focus on that.
So, ma'am, that is something we are very much on to, that if there is a new information that requires to be generated, which is not there into prospective or retrospective data, for sure we would be looking to the academic setups primarily to help us in generating the data. But what other part is what we are talking primarily is the real world evidence into a approved scenario, into the same kind of setup which is there in the label. But we want to have a kind of say Indian data or a kind of say larger mass data which is not there as a publication. So for
So it
that we
can be
would look forward for
retrospective.
your yeah. So whatever the data you have, if it's possible, we can get it in any form. We can just transcribe into analyzed way of format, and then we for sure will come back to you with our information so that it can be taken to a good publication ahead. And at the same time, if you feel that you want to generate a prospectively experiences in this manner, we are ready for that too. But we just look for your kind of say positive node in that direction. And our team would approach you for all the protocols and everything in coming days.
Yeah. So medical support we can give. We can share you the CRF protocol and all that all will be needed. And
Ma'am, आप
maybe we can
mute
do
पे जाइए.
multicentric thing also, sir, if everyone aligns.
Yeah.
Okay.
Okay. So next, the CMEs. Okay. So we have already planned some of the CMEs has started in different regions. So we'll be doing CMEs throughout India in different regions. Will be around 50 or more if possible. So we want you all to be the speaker for the same. CME slides have been shared with all of you, and definitely all the suggestions are welcome. What we can change in the CME slides, or if we can add something, or if you have any studies or data that can be added in the CME slides, so please let me know. I can add that, and we can do
Can we look
CME.
forward to make a planner
Hmm.
for that with your consent and consultation, that
Exactly.
wherever you agree to help us
Agree
in
to.
spreading the word about your
Hmm.
experiences and expertise about this product. We would like to have a kind of say small group meetings, a kind of say very close 10-15 doctors meeting, or on a larger scale in the form of a CME or a panel discussion, be it physical or virtual.
User,
That is
non-user.
completely based on your uh, availability and your convenience. We can plan it sitting with you one-on-one, but I would just right now looking forward for a confirmation from your end. Parag sir, as you just simply said, so I can make out that yes from your side.
Yeah,
Absolutely,
yeah.
I'm looking
Because
forward.
that is something I've been using, and I'm interested in propagating the knowledge about.
Yeah, I know. Thank you so much, sir.
So
Palaniappan
with
sir.
Asha ma'am, we are having maybe, sir, in the last week of August in Indore.
Okay.
Okay, yeah.
Can we plan it as someone suggested that this is more useful if we are doing into medical colleges, or a kind of say tier two kind of a segment wherein the utility or the efficacy would be much better, like Ashwin sir suggested once. He said that
Hmm.
going to a smaller segment would be
Ashwin sir,
having a
huh?
much better utility.
Hmm.
So, Amit,
And Ashwin sir,
let's not only focus the medical colleges, because sometimes the cost may be an issue. So let's have both the medical
yes,
college
yes,
because
yes,
they
yes.
have bigger
I'm not restricting to
numbers,
medical. I'm
uh,
saying that
uh,
one of the, course,
Hmm.
of course,
and
True
then plus
society,
government sector.
practitioners,
Yeah,
because private sector doctors are more likely to use this unless it is
bilkul
true,
sir, bilkul,
subsidized for a
bilkul.
government setup.
true
Okay. Right
societies,
now,
and
what I'm
make
looking
sure
forward
that
is
yes, it is a mix of all. True
Hmm.
societies, it will be the best thing. True
Okay.
Foxy societies,
So we
yes.
need to engage a Foxy, and then after probably it will be going to both of the scenario, like
Yes.
private sector as well as government sector. Yeah, fair enough. Fair enough.
So,
sure.
so conducting this in tier two or tier three cities will be more beneficial, or if we go for in urban areas.
Looking at the cost for the time
Hmm.
being, I think
Hmm.
bigger cities or would be there will be more takers in the bigger cities. That's what I
Okay.
personally.
Okay.
Okay.
Okay. Great. Ashwin sir, your suggestions? Suresh sir?
So is Ashwin sir mute?
I think most of the things have been discussed already.
Hmm. Hmm. Yeah.
I think most of the things like price also, and the video thing. I think we should make because now we are living in millennials versus Gen Z
Hmm.
nowadays. So better we should give awareness to the society by means of Insta and Facebook things. Like we can make, like, if Parag Biniwale sir makes a Insta video of just 30 seconds regarding this, how to use,
Hmm.
and put in a community where obstetricians are more using it. So it will be a hit, I think so.
Okay.
Definitely, we can do that.
Yeah.
Palaniappan
Okay.
sir?
It's
Yeah.
just to generate awareness only, because
Awareness,
most of the
correct,
people
correct.
are using
Yeah,
Dinoplexone.
I will also
Right.
agree with it, and I'm sure making it more popular is something which is important. And yeah, Insta, Facebook, and things like that are reasonable good options rather than going out and meeting each individual doctors and
Yeah.
telling them I've got a product and so please use.
Okay,
It's
okay.
better to you work on social media, because
Social
everyone is
media.
having mobile in
So
their
we were
hand.
thinking of to go ahead with hashtag go for normal. So what are your suggestions? So with under the name go for normal, we can do all this
Like
social
some
media.
suggestions are there regarding even the patient awareness, or like as Samim said, that there's something parallelly should be done on the patient engagement part also, to make them comfortable in understanding the importance of
Hmm.
and the preparation of induction. So everything should be covered under an umbrella of hashtag go for normal,
Go
so
for
that
normal.
this also can be included for the doctors also. So doctors and patient both
Hmm.
can be covered under the same umbrella rather than using the brand name, so that it doesn't look commercial also in that case.
Yeah.
Yeah.
So
See,
this
the
will be
hashtag is
considered as
fine,
a
but
awareness
when
activity.
see, the hashtag
Yes,
is
sir.
absolutely fine, but then when you are talking about the content, let's not use the word normal delivery, because Palni will also agree, because we are using
Vaginal
vaginal
birth.
birth as a standard
Vagina.
Yes.
terminology rather than a normal delivery, because
Understood.
cesarean section is not abnormal; it's
I
another way
got
of
it, got it,
delivery,
got it.
right? So
Point
let the
taken. Point
hashtag be
taken.
like that, but then we have to make sure that when we create the
We
content,
talking.
we use the word
It's
vaginal
vagina.
birth. Vaginal
True.
birth.
Oh,
Or
Very
okay.
true.
natural. Natural.
Natural. Okay.
Natural.
No, see,
Then
when
Okay.
we
we
can.
use natural birth, cesarean becomes
Hmm.
unnatural.
Yeah. And
Okay.
Asha,
So
induction
we'll
is
stick
not
to vagina.
natural.
Ah,
So let us use vaginal birth, cesarean section.
vagina.
Okay.
Done.
Okay.
Okay.
Yep.
Done, sir.
Is that it? We
So
call a
thank.
day.
Yeah.
Yeah.
Yeah, we call a day. We would just like to pass
Thank
it
you, and
on
I would
to.
like to welcome Nimesh Modi to give a thank you note to the panelists and everyone.
Yeah. So on behalf of Corona Remedies, I take this opportunity to extend my heartfelt gratitude to all the esteemed panel doctors who took out their demanding schedule to attend this today virtual steering committee meeting. Your presence, insights, and active participations has greatly enriched our discussion, sir. The minutes of meeting which we have discussed over here, we are in a few more days, we will be sharing with you all. Once again, thank you from Corona Remedies for your valuable time and contribution. Cheers for your spirit and enthusiasm. Thank you, team. Thank you.
Thank you so much.
Thank you
Thank you,
all.
everyone.
Bye
All the
bye.
doctors, thank you so much.
Yeah.
Yeah.
Bye.
Thank you very
Bye.
much. Thank you very much,
Thank you.
everyone.
Thank you.
Thank you,
Thank you.
Tejas ji. Thank you. Bye.
Thank you.
Thank
Thank
you.
you very much. Thank you.
Once I'm stopping recording.
Hmm.
Yep.
So congratulations to medical team for
Yeah.
successfully conducting it. And
Actually,
one
Ashwin
thing.
Kakar is with us
Oh,
in
Ashwin
the
sir
meeting.
is there.
yeah.
Uh-huh.
Ashwin sir is there. Oh,
Okay. Maybe he
so
has not left it.
okay. So I just wanted to highlight one
Yeah,
thing.
sure.
Ashwin Thakkar sir is there here, and the question is also there. In last ad board meeting, we have finalized that we should do vaginal wash, and we have highlighted that point throughout the year. And Ashwin Thakkar sir has strong support for that point, but I don't know today why he has not spoken about it.
I think he has just joined and he was not
No,
there
no,
in the
he
meeting
was there in. So
because he didn't speak. We have took his
he
name also once or twice. Maybe he must be in.
he is in meeting throughout. He was there in throughout the meeting. But
Right.
that one thing was my concern. I thought I should
Mhm.
ask, but the majority of doctors,
Mhm.
See,
they are
Nilesh,
saying,
what I understand, one thing about this is that he might have suggested that, and that probably was a part of a communication. Now, this panel
Correct.
said that it is not something which we should aggressively put it into the checklist.
okay,
Mhm.
Okay, it's not to